So examination of the hip joint. Again, the hip joint have the same flow: look, feel, move, and special test. Number one is exposure of the patient, introduction to the patient, taking consent from the patient, and cleaning hands, as in every other joint in the body. So you expose the patient. The patient should be in shorts, and you should be able to see the spine. You should be able to see the legs. That's adequate exposure for a hip examination. So again, you stand the patient in an open space, and you look at the patient from the front, from the side, and from the back, and you go around the patient one time, looking for any deformities, scars, swellings, muscle wasting, any of these problems. And the posture of the hip or posture of the spine. Then you get the patient to walk, and you comment on the gait of the patient. So the patient may have an intelligent gait, they may have a short leg gait, they may have a Trendelenburg gait. So you have to see the patient walking and assess the kind of gait that the patient has got. Now, in the hip, we do one special test before we put the patient into the bed, because it's very easy that it's easier for the patient and easier for the examiner that when you're examining the patient, you do standing tests first, and then you get the patient to go into the bed and do all the tests in the bed. So one special test we do in the hip is called as the Trendelenburg test. And this is a test for abductor weakness. In patients with severe hip pain and abductor weakness, the Trendelenburg test will be positive. And this test you do by standing the patient on one leg and supporting the patient's hands on your hands so that they don't fall. And you get them to stand on one leg and then the other leg for 30 to 40 seconds. Once you've done the inspection and you've done this special test, you get the patient to go into the bed, and comes the second step, which is the feel. So you feel the soft tissues around the hip, because hip is a deep joint. You cannot exactly see the bones of the hip joint, but you see structures around the hip. You see the soft tissues around the hip, and you feel them as well to see if there is any tenderness in that area. The third thing is move. So the movement of the hip that you can assess are flexion, internal rotation, external rotation, abduction, adduction, and finally extension. So you do it first, the patient has to do it actively, and then you can do it passively to see if you can get any more movement. In patients with arthritic hips, the movements will be restricted and painful. Coming to the special tests. For the hip, there are two main tests that we do. One is for leg length discrepancy. There is an actual leg length discrepancy, and there is an apparent leg length discrepancy, and we will show you how we do these two tests. The second test is for fixed flexion deformity of the hip, and that is called as Thomas's test. And that's also a very good test to do to assess for the arthritis of the hip and assess for any deformity of the hip. Now we're going to do an examination of the hip joint. This is Dr. Shahir. We are going to examine his hip joint today. As in any other joint, the first thing will be taking consent, introducing yourself, and washing your hands properly. So, hi, I'm Dr. Ahsan. Is it okay if I examine your hip?
Of course.
Do you have any pain anywhere?
No, I don't.
Okay, do you have any difficulty walking?
No, I don't.
Okay. So, having asked these questions and washing my hands, introducing, taking consent, we're going to start with the examination. Again, look, feel, move, and special test. So we'll start with the exposure of the patient. Now, exposure ideally for a patient with hip should be in very small shorts, and the back should also be exposed in that, because we need to be able to see the spine. So you should be able to see the full patient. Now for inspection, we get the patient to stand straight. Can you please put the hands on the side? And we look at the patient from the front to see any deformities, scars, swellings, the shape of the pelvis, if he is standing straight or not. And then you go around the side, looking at the skin around the hip, coming onto the back, looking for any muscle wasting, any scars, any deformities, looking at the back as well to see if there's any scoliosis of the back or any deformity going to the side, for any kyphotic deformity of the back or any fixed flexion deformity of the hip, any scars on this side, and then you come back to the front, and this completes the inspection or looking part of the hip. Then you get the patient to walk. Can I please see you walk?
Of course.
From the wall to here? Yeah. Walk here, and then can you please go back to the wall? Just normal walking like you normally do. Okay, we look at the gait. Turn around, please. Okay, that's fine. You can stand here. So we look to see if the patient has got a Trendelenburg gait, a short leg gait, or an intelligent gait. and we have to describe what kind of gait this patient has. Now, one of the special tests for the hip is done while the patient is standing. So before I get the patient into the bed for the feel and move and special test part of the hip, I'll do one special test with the patient standing, so I'm not getting him in and out of the bed again and again. And that special test is called as a Trendelenburg test, which is done for abductor weakness. So we're going to do a Trendelenburg test for the patient. The easiest way to do this test, the way I do it, is to stand the patient in front of you, and please place your hands on my hands, and now lift up one of the legs. So patient will lift one leg, and you are supporting the hands of the patient, and you're seeing if the patient is tilting on one side or the other. The leg being tested right now is the leg on the floor, and we are testing the abductors on that side, which should stabilize the patient. If the abductors are working well, the patient should be able to stand without putting any extra weight on my hands. Okay, thank you. Now the other side. So you test that the patient leg on the ground is stable, and patient is not putting any extra pressure on one hand or the other hand, and I don't need to give extra support to this patient. Thank you. So that is the Trendelenburg test. Some people do it by sitting in front or sitting behind, stabilizing the pelvis. That feels a little bit awkward. This is the most simplest and easiest way to do the Trendelenburg test. Now we come on to the feel part of the examination of the hip joint. Hip joint is a deep joint, and it's difficult to feel the exact joint itself, but you just feel the soft tissues around the hip, and you see if there are any tenderness around the hip in the soft tissues or in the region of the joint. So we feel the anterior spherical spines, both sides. Always look at the face of the patient while you're doing this test. Any pain anywhere, sir?
No.
We are feeling the greater trochanters, both sides, feeling the area of the groin and the buttocks. Any pain anywhere?
No.
Feeling the proximal thighs. So palpation or feeling part in the hip joint is limited because of the depth of the joint itself. So we have completed the feel. Now the move. So the movement again will be passive and active. Can you please bend the hip fully, the right hip full? Any problem, any pain? Okay, so this is around 110 degrees of flexion, straighten up. Flex this hip fully. This is around 100 to 110 degrees of active flexion of the hip, down. Now push this leg towards me. This is abduction, okay, backwards. Onto the other side. Yes, okay. This is abduction, which is around 35 to 40 degrees. Now bring this leg to this side, cross this leg. This is adduction of the hip, okay, that's fine. Now to the other side. This is adduction of the left hip, okay, that's fine, which is about 15 degrees. So now we're going to do passive range of motion of the hip joint. So for the right hip first, let me flex it. Tell me if you have any pain, sir. So this is complete flexion of the left hip, which is around 140 to 150 degrees. Okay, then there is internal rotation, which is this movement of the hip. This is around 40 degrees. External rotation, which is this movement. This is around 60 degrees as well. Down. For the abduction, we stabilize the anterior superior iliac spine and bring the leg outward. This is about 45 to 50 degrees. And adduction, we bring the leg this way. This is around 20 degrees. Now similarly, for the left leg, flexion. This is complete flexion, around 130 degrees. To do rotation, we bring the leg back to neutral or 90 degrees of flexion. This is external rotation, about 45 degrees. This is internal rotation, about 30 degrees. Okay, down. To check for the abduction and adduction, we stabilize the anterior spherical spines both sides. This is abduction, around 50 degrees. This is adduction, around 25 degrees. So these are the active and passive movements of the hip joint that we test. Now coming on to the special test, the two main tests that we do for the hip in bed, one is the actual and apparent leg length discrepancy, and the second is a fixed flexion deformity of the hip. Now to check the flexion and extension or the flexion deformity of the hip, we do the Thomas test. Can you please bend the two knees and hold it with your hands? So to do the Thomas test, we ask the patient to bend the two hips fully and hold the two of them with the hand. Now can you place this hand here and put this leg straight on the ground? So I have my hand behind and under the lumbar spine of this patient, and I'm checking if the knee is down on the floor. and this hip has no fixed flexion deformity. If this patient had a fixed flexion deformity, then his leg will be like this, and he would not be able to put it down on the bed. Okay, similarly, now bend this leg full, and again, now it's the left leg being tested, and we can see there is no fixed flexion deformity of the hip. If there was fixed flexion deformity, the knee will be bent up like that, and this happens in patients with arthritis. Okay, thank you. Now, checking for leg length discrepancy. For that, we mark a point over the anterior superior iliac spine and mark a point over the medial malleolus of the patient. And there should be two consistent points, left and the right side. And for apparent leg length, it's a central point which could either be xiphisternum or the umbilicus to the same point on the medial malleolus. So for this test, we need a measuring tape. So we take the measuring tape and for the apparent leg length discrepancy, you put it at the level of the xiphisternum, and then you go to this point on the medial malleolus and you mark the length here, and then similarly you go to the other side and you mark the length on the other leg. For the actual leg length discrepancy, the point that you marked for the anterior superior iliac spine, you put a measuring tape on that, and then you bring it down to the same point over the medial malleolus. Here, this is the actual length of the leg. Similarly, you check the other leg, same point over the anterior superior iliac spine and the same point of the medial malleolus, and this is the actual length of the left leg.